Good day, class. We are now in Module 10 on surfactant agents. You've heard this term in our previous module, but this time, this is used to keep the lungs open and function properly, especially in newborns. This is relatively a short module, but will connect basic physiology to real practice, so somehow we'll touch a review of your cardiorespiratory anatomy and physiology. By the end of this lesson, you should be able to understand the terms that is used in surfactant agents, the drugs that we used, specifically the exogenous surfactant agents, what's the mode of action of these agents, the route of administration, recognize the hazards and complications of this surfactant therapy, and assess the use of surfactant therapy, how we also manage patients receiving this therapy. This is a slide from our Module 9, and we talk about surface active agents here, or we also call it surfactants, because mainly they reduce the surface tension between the mucus and airway surface. So yung effect natin dito is mababa yung adhesion, less yung adhesion, mas madaling gumalaw at kumalas yung mucus. So this is, sabi nga natin, under mucokinetic agents, pinapagalaw. Mas madali niyang pinapagalaw yung ating mucus. And this is different from the surfactant agents here in Module 10. Here in Module 10, the surfactant is actually a replacement therapy, meaning we are giving the actual substance that the body lacks. While in Module 9, the surfactant effect is mucokinetic, meaning it helps move mucus and not replace surfactant. And our target for Module 10 is the alveoli, while in Module 9, airway mucus ang target natin. So magkaiba sila ng location. One is deep in the lungs, and the other is in the airways, sa bronchi. For the main action, nasabi na kanina to, for Module 9, it decreases mucus adhesion sa airway walls. While here in Module 10, it decreases alveolar surface tension. As a result, for Module 10, which we will later discuss more, is it prevents alveolar collapse, therefore improving gas exchange. For Module 9, ang result natin dito is the movement of the mucus. Easier mucus movement, mas madali siyang mailabas. It improves clearance. And in Module 10, the mechanism is it acts between the air-liquid interface, between air and liquid interface in alveoli. But in Module 9, it acts at the mucus and airway interface. So examples natin, sa Module 9 natin, your bronchodilators and your hypertonic saline solution. While here in Module 10, you will meet Survanta and Curasurf. Let's start with a case. We have a premature baby born at 28 weeks, and after a few minutes, napapansin natin mahirap siyang huminga. There are chest retractions and mababa ang kanyang oxygen saturation. Ang question natin dito is, why is the baby having difficulty breathing? Barado ba yung airway niya? Or something else is happening? At first, you might think, because natapos natin yung ating Module 9 on mucus-controlling drugs, baka may mucus, baka may obstruction. But in this case, the problem is deeper than the airway. The real issue is in the alveoli. And remember, sa 28 weeks natin, the lungs are still immature. Kulang pa sa surfactant. So pag kulang sa surfactant, what happens is mataas ang surface tension, there will be alveoli collapse, mahirap mag-expand ang lungs, and the result is RDS. medyo, I don't know for you kung you can follow kasi meron na tayong cardiorespiratory anatomy and physiology. So, the key idea here is hindi barado yung daanan. Hirap lang talagang bumukas yung alveoli. And that's why this baby cannot breathe properly. Ang tanong natin, how do we fix this problem? Kung ganun ang problem natin. And ang sagot dyan is simply through surfactant therapy. So let's have a quick anatomy and physiology review of our alveolus. Kasi dito nangyayari yung pinaka-importanteng function, which is your gas exchange. Inside the alveolus, may dalawang main cells tayo. Type 1, these are the type 1 main cells. Your type 1 pneumocytes, ito yung flat or squamous cells. They cover most of the alveolus and ang function nila is for gas exchange. So, oxygen in, carbon dioxide out. We also have the second type, which is your type 2 pneumocytes. Ito naman medyo cube ang itsura, cuboidal. It's not for gas exchange, but it has two important functions. First is your surfactant production. Inside these cells, itong mga orange na makikita nyo, may stored substance tayo called surfactant. So, pag na-release siya, nagpo-form siya ng itong orange na nandito, nakikita nyo. Thin layer dito sa lining ng alveolus. Second function of your type 2 pneumocyte is it can regenerate type 1 cells kapag nasira. So, parang repair system siya ng alveoli. Let's focus ourselves dito sa surfactant. Ano bang ginagawa nitong surfactant? So, it creates a layer between the air na andito and water sa alveoli. Saan may water? So, yan. Dinrawing ko na. May blue tayo dyan. That's the water. Normally kasi, itong tubig sa alveoli natin, andyan sa fluid lining. And yung water, may property siya that we call surface tension. Ano tong surface tension? Very basic, pero isa-isahin natin. Surface tension is the force that pulls water molecules together. So, gusto nila, join together, magkakadikit sila. Example, when you drink water, for example, this is a glass of water. No? Makikita nyo parang there's a concave, may pa-cave doon. No? Kasi they are pulling each other together. That is what we call surface tension. Sa chemistry nga natin, ang normal figure dito is yung merong insect sa taas ng water and then makikita mo yung surface tension. So, the problem, kung walang surfactant na pinroduce itong ating type 2 pneumocyte, magiging mataas yung surface tension. And it will lead to RDS. So, tingnan natin yun, step by step, yung pathophysiology. Although, alam nyo na, let's just review, no? So, may fluid lining sa alveoli, the blue one. Normal ito, required siya for gas exchange. But, the water has the property na surface tension. So, they tend to pull each other. They pull inward. So, kung ito, may water yun, they will tend to, ayan, na-draw ko na pala yung arrow beforehand. They pull inward. So, without surfactant, walang kokontra sa force. So, walang pipigil. Walang magbabawas ng surface tension. So, mataas ang tension, that's the start of collapse ng alveoli natin or what we call atelectasis. Dahil sa inward pull, the alveoli become unstable, lalo na during expiration. Yan. So, nagsasara yung ating alveolus. Parang basang plastic na nagdidikit-dikit. Ang hirap niyang buksan kasi nagdikit yung water doon. So, sa next na paghinga, sobrang hirap buksan. That is according to the physiology na later we will refresh ourselves, yung Laplace concept. Mataas ang surface tension, mataas din ang pressure needed to open these alveoli. So, yung baby needs more effort and more pressure. So, what happens is, mababa yung lung compliance o nagiging stiff yung lungs. Matigas siya at mahirap i-expand. So, compliance is a basic term sa inyo, no? It's the ease of expansion. Kung gaano kadali huminga. So, low compliance meaning mahirap huminga. And what happens to gas exchange here? So, gas exchange natin, because alveoli are collapsed, oxygen cannot enter and carbon dioxide cannot exit. This leads to hypoxemia and low oxygen and hypercapnia or mataas na carbon dioxide. So, magkakaroon tayo ng respiratory acidosis. And this is the time that the baby will show itong mga symptoms ng RDS, no? Grunting, retraction, nasal flaring, tachypnea. Because they are trying to keep the alveoli open. So, that's why it leads to itong tinatawag na nga natin na RDS or the respiratory distress syndrome. It's a combination of the alveoli collapse, poor oxygenation, and increased work of breathing. Kapag meron naman tayong surfactant sa alveoli, bumababa yung surface tension. So, pag bumaba yung surface tension, lesser yung inward pulling. Wala na tayong masyadong inward pulling dito. So, nagiging stable siya. So, the alveoli stay open kahit during expiration. Tumataas yung lung compliance. Nasabi natin, the ease of inhaling and exhaling. Tumataas yung lung compliance, mas madaling mag-expand ang lungs. Kapag mas compliant yung lungs, mas konti yung effort sa paghinga. So, lesser yung work of breathing. And of course, kapag open ang alveoli, mas efficient ang gas exchange. So, oxygen goes in and carbon dioxide goes out. And ang overall outcome natin dito is normal ang breathing. So, that's why alveoli, open alveoli, kapag meron tayong surfactant, means easier ang breathing natin and better oxygenation. Balikan natin itong case. A premature baby is born at, sabi natin, 28 weeks. And that detail is very important kasi at 28 weeks, nasabi ko kanina, the lungs are still immature. Specifically, this is the stage where type 2 pneumocytes are just starting to produce surfactant. Pero hindi pa sapat yung amount. So yes, may surfactant na nagsisimula pero kulang pa and it's not yet effective to keep the alveoli open. Bakit at 28 weeks? But hindi in months? Kasi iba-iba yung number of weeks. No, mas specific yun. In obstetrics, more precise, 28 weeks is around 6.5 to 7 months. It actually marks the start of the third trimester. At around 7 months, ito yung critical part, the lungs are just starting to produce surfactant. That's why yung kapag mga premature baby, alam na nila yun agad. Minomonitor nila agad yung lung health ng bata. Kasi very high yung risk for respiratory distress syndrome. So, it's simply yung physical principles of your surfactant therapy It's to replace the missing pulmonary surfactant. It acts on surface tension sa ating gas-liquid interface and the interrelationship of the surface tension and pressure is described by Laplace law. So, tingnan natin yan, itong mga principles na to in detail. Let's start with surfactant. So, surfactant, this is actually a surface active agent that reduces surface tension. So, it is, in other terms, anti-surface tension. So, ninenegate niya yung surface tension. So, para mas madaling maintindihan sa amin ng mga gumagawa ng mga drugs, isipin nyo yung detergent. Kapag may sabon yung tubig, hindi siya buo-buo. Nag-i-spread siya. Ibig sabihin, mababa ang surface tension. Ganon din yung alveoli. May thin layer sa loob. At ang fluid na yan, naturally, nagkakos ng surface tension na humihila paloob. So, kung wala yung surfactant, yung orange part here, tuloy-tuloy yung inward pull. Inward pull. Yan. Kaya ang alveoli, madaling mag-collapse, lalo na during expiration. So, anong ginagawa ng surfactant? It forms the layer between this air and the fluid na nandito sa ating lining. At binabawasan niya ang pulling force. So, the result is, mas stable yung alveoli, mas madaling mag-expand. Dito sa diagram natin, makikita niyo yung surfactant layer. Nasa ibabaw siya ng fluid lining, acting like a protective layer. Sa premature babies, kulang ang surfactant, kaya mataas ang surface tension, nagko-collapse yung alveoli and leading to RDS, Respiratory Distress Syndrome. Ano nga ba tong Laplace law? So, Laplace law describes the relationship between three things: the pressure, the surface tension, and the radius. So, if you are familiar with the formula, makikita nyo yan. The pressure, the surface tension, and yung radius. And how much pressure is needed to keep a bubble open or structure open is what it basically tells us. Ito yung kailangan natin. And ang important variables dito na laging tatandaan, kapag mataas yung surface tension, mataas yung pressure. Pag mababa yung radius dahil nasa denominator siya, pressure increases. In the lungs, we're not dealing with a full bubble. We're dealing with alveolus with only one single air liquid interface. Anong ibig sabihin nito? Si soap bubble kasi natin, yung kaninang merong formula na 4 surface tension over radius. Meron siyang inner, nasa loob na liquid air as surface, at meron din siyang outer, liquid din, and this is may liquid part din siya doon, and then may air din siya doon. Pero sa alveoli, isa lang. Wala tayong dito sa labas, outer parts. Inside lang tayo. So, meron lang tayong liquid and air interface dito sa loob. So, instead of 2 surfaces, isa lang yung surface natin. So, yung Laplace law sa alveoli becomes 2. 2T or 2 surface tension over radius, not 4T over radius. Dahil isang surface lang, mas sensitive ang alveoli sa surface tension. So, kapag walang surfactant, mataas ang surface tension, madaling mag-collapse ang alveoli. And what happens during expiration? So, during expiration, the radius of our alveoli decreases. So, the pressure, so sabi nung, natin kanina, no? Formula natin, 2T over R. Kung mas maliit yung equals pressure sa Laplace law, So, kapag mas maliit yung ating radius dito, tataas yung ating pressure. Meaning, mas madaling mag-collapse yung ating alveolus. So, here makikita nyo, the surface tension is pulling inward. So, pressure required to keep it open mas stronger kapag mas maliit yung alveolus. That is what exactly happens in RDS. Simply, kung mataas yung ating surface tension, mas malakas yung puwersa or pressure na humihila paloob ng ating alveolus. And this can lead to two problems. It can collapse yung ating alveoli or mahirapan silang mag-open. So, every time you breathe out, lumiliit yung alveoli. So, mas tumataas yung collapsing force. That's why expiration is the critical phase. Now, if you lower the surface tension, mas madaling mag-open ang alveoli. Now, let's move to clinical use. Kailan natin ginagamit ang surfactant in real patients? Exogenous surfactants are given for treatment or prevention of RDS in newborns. Meaning, nagbibigay tayo ng surfactant from outside, exogenous, nasa labas, para palitan yung kulang sa baby. Remember that the main problem in RDS is immature lungs. Kulang sila sa surfactant. That's why mataas yung surface tension at nagko-collapse yung kanilang alveolus. There are two modes of treatment. Meron tayong prophylactic treatment at rescue treatment. Sa prophylactic meaning prevention. Ibibigay ito kahit wala pang symptoms or severe symptoms para maiwasan ang RDS. Sinong mga may kailangan nito? Very low birth weight ng infants, infants with immature lungs kahit mataas ang weight, babies at high risk of developing RDS, mga lumabas ng 7 months or below. These are babies na alam natin na kulang ang surfactant, so we act early. Ang goal natin dito is prevent collapse before it happens. For the rescue treatment naman, or retroactive, rescue nga. So, binibigay kapag may RDS na. Hindi na siya prevention. This is already treatment. So, those with RDS. So, when the baby is born, meron siyang RDS, then we give the surfactant to improve the lung function. Dito sa image natin, you can see the effect of the surfactant when you add an exogenous surfactant. Without the surfactant, yan, high yung surface tension, low compliance, increased work of breathing. With surfactant, malolower yung surface tension, increased compliance, at easier yung breathing. And this graph shows that after natin, itong lighter color, after natin magdagdag ng surfactant, for the same pressure, mas mataas ang lung volume, meaning mas efficient na yung lungs. Let's talk about what surfactant is made of, because understanding the composition helps us understand how it works. So, pulmonary surfactant is made of two things, lipids and proteins. So, ang major component natin dito is the lipids. Siya yung pinaka-important. It makes up about 85 to 90% of surfactant by weight. So, majority talaga, lipid-based siya. Most of these lipids are phospholipids, especially phosphatidylcholine. And ang pinaka-important dito is your dipalmitoyl phosphatidylcholine or DPPC. It's the main substance responsible for lowering surface tension in the alveoli. So, if you remember one thing here, DPPC is the key player. Pero important rin itong second component natin, which is your proteins, making up about 10%. So, there are 4 types. surfactant protein A, B, C, and D. And these proteins help surfactant work effectively. So, para siyang synergistic effect. So, it's not lipids alone. So, kailangan ng help ng ating proteins. Si surfactant B and C natin is known for spreading the surfactant. So, hindi lang siya in one area. And SPA natin regulates secretion and recycling. Yung SPD, hindi pa masyadong alam kung anong role niyan. But without these proteins, the surfactants will not spread properly sa alveoli. So let's look at how surfactant is produced, released, and recycled. Maganda nga yung report ng isang group, no? 3 R's, sabi nila. I forgot the first R, but the second and third R, release and recycle. So we start with the production. Where is it produced? So maalala nyo yung figure natin sa second slide ata. Meron tayo nung type 2 pneumocytes. So the surfactant is synthesized in type 2 alveolar cells, and it is stored in structures called lamellar body. So itong lamellar body natin, para siyang storage vesicles. Parang warehouse siya ng surfactant. Next is, now that alam natin kung saan siya napoproduce, paano siya nare-release? So, nare-release siya. At ang major trigger niya dito for release is lung inflation. So, every time the lungs expand, especially during breathing, it stimulates surfactant release. So, parang automatic response ng lungs ang pag-release na yon. Gaano karami yung sinesecrete? So, about 10% of the intracellular surfactant is released every hour. Hindi siya one-time release. Continuous process siya. And meron tayo nung last na R natin, which is your recycling. One of the most important concepts of surfactant is recycling. About 90 to 95% of the surfactant is reabsorbed. Ayan, makikita nyo. Nare-reabsorb siya and reused by type 2 cells. This is why, kahit na galing sa labas or exogenous yung surfactant mo, it's effective because the body uses that and the body recycles that and maintains the surfactant pool. But not all surfactants are the same. They differ sa ating source, composition, and effectiveness. So, meron tayong 3 classifications of exogenous surfactants: natural or modified natural, synthetic, at saka synthetic natural, or what we call yung genetically engineered exogenous surfactant. We start with the natural or modified natural surfactant. This is the most important and most common type used clinically. Derived siya from animal lungs, usually a cow or pig. It contains phospholipids and surfactant proteins. Siya yung closest to natural human surfactant. It's important because it contains protein. And sabi natin kanina, those protein, kahit 10% lang yon, it helps to spread the surfactant. Spreads yung lipids natin better and works more effectively in the lungs. Ang limitation lang natin for this natural modified surfactant is wala siyang SPA or the surfactant protein A na nasabi natin kanina affects regulation and recycling. Next, we have yung synthetic surfactants. Synthetic, so hindi siya natural. These are man-made in the laboratory, so wala tayong animal source. So purely chemical composition, wala siyang surfactant proteins. Yun ang wala sa kanya. Advantage nito, it's safer in terms of wala tayong infection risk walang immune reaction kasi wala tayong proteins. But the disadvantage, since wala siyang proteins, less effective siya compared to natural surfactants kasi wala yung proteins that are needed for spreading. And lastly, yung ating genetically engineered or synthetic natural. So, ito yung sinasabi nating future of surfactant therapy. It's a combination of synthetic and natural, which would be created using recombinant DNA technology. So, ang goal natin dito, structurally, like natural siya, pero lab-produced. So, yung synthetic kasi natin, ang kulang dito, kaya hindi siya parang si natural, wala siyang proteins. So, ang goal natin for synthetic natural, meron siya nung lipids, meron din siya nung proteins. But, as of now, wala pa tayong available drugs for that. So, again, natural, synthetic, natural. Natural, the best, meron siyang proteins and lipids. Synthetic, meron lang siyang lipids, pero wala siyang proteins. Synthetic, natural, wala pa tayo nito. Let's zoom in dito sa ating synthetic surfactant. So, sabi natin, it's man-made. Sa laboratory lang siya. Walang kahit anong ingredient na galing sa natural sources. And, major advantage is safety. Since synthetic siya, nasabi kanina, walang risk of infection transmission. So, wala tayong mga foreign proteins na pwedeng mag-cause ng immune reaction. So, mas clean siya in terms of source. Then, disadvantage niya, nasabi natin kanina, wala siya nung proteins. So, dahil wala siyang proteins, they do not perform well as your natural surfactants. Kasi, yung kanina natin, B and C, we use it for spreading. And A is for reuptake and recycling. So, kahit may lipids ka, kung walang proteins, hindi optimal ang function ng inyong surfactant. Now, let's look at 3 surfactants that are in your textbook. Si beractant, calfactant, tsaka poractant alpha. I love to put everything together in one comparison table para mas madali nyo makita ang differences nitong tatlong surfactants. So, all 3 natin are used for RDS but they differ in source, protein content, timing of use, at saka clinical preference. So, we start with the source type. So, source type, si Surfactant, galing siya kay cow. Yan. Bovine means lung. It's modified. Sa InfaSurf, bovine din siya. Lung lavage, modified. Sa CuraSurf or poractant, so pork ito, it's from pig. Natural. Pig lung. So, dalawa lang from cow, isa from pig. Proteins naman, in terms of proteins, si Surfactant tsaka si InfaSurf ay meron silang SPB and SPC. Both walang SPA. Si CuraSurf, SPB lang ang meron. Wala, ibig sabihin, lahat sila walang SPA. Remember, SPB and SPC are important for spreading. For as prophylaxis, Surfactant is used for very low birth weight given 15 minutes of birth. Si InfaSurf naman for those with less than 29 weeks gestation. Si CuraSurf, we don't use it primarily as prophylaxis. Ginagamit siya for treatment. So, if the question is about early prevention, right after birth, si Surfactant yon, 15 minutes after. So, for as rescue treatment, you can use all, but si Surfactant within 8 hours of birth, si InfaSurf within 72 hours, intubated, and si CuraSurf naman, mainly ito ang use niya for RDS treatment. So, all three can be used for rescue. Other uses, itong si Curasurf natin, meron siyang additional use for MAS or your meconium aspiration syndrome and your GBS pneumonia. So, though itong MAS at saka GBS pneumonia, hindi pa labeled ang use niya on that. For RDS pa rin talaga yung. Now we go to the dosing and administration differences. We start with the initial dose. So for Surfactant, that's 4 ml per kilograms. And for Infasurf, that's 3 ml. And for Curasurf, that's 2.5 ml per kilogram. But that 2.5 is actually 200 milligram per kilogram. So kahit mas maliit ang volume ng Curasurf, siya ay mas mataas ang concentration. Siya ang may strongest dose. Now we go to repeat dose. For Surfactant, that's every 6 hours as needed. For Infasurf, that's every 12 hours with a maximum dose of 3 doses. And for Infasurf, it's also 12 hours. Curasurf, it's also 12 hours. Pero that is only a maximum of 2 doses. So, simply, si Surfactant, ang mas frequent ang kanyang dosing. Si Infasurf tsaka si Curasurf every 12 hours. For the maximum dose, si Surfactant, as needed nga, depends on the response of the patient. So, Surfactant, until 3 doses lang. And sa Curasurf, it's kapag na-reach na niya yung 5 ml per kilogram. That's the maximum dose. And this is one of the important feature ng ating surfactants, no? Aliquot. What is an aliquot? Aliquot is a portion or divided part of the total dose. So, for example, yung initial dose mo is 4 ml. So, sabi dito, you give 4 doses. So, instead of giving the whole 4 ml dose all at once, the dose is split into smaller parts and given one part at a time. Bakit may aliquots for a surfactant therapy? Because the surfactant is being given into a baby, into a very small neonatal airway. If you give the entire dose in one push, pwedeng mabara ang airway, pwedeng biglang bumaba ang oxygen, pwedeng magkaroon ng bradycardia. So, ano ginawa mo sa mukha mo? Sorry for that. Commercial lang. So, we give it in aliquots so to make it safer and to help it spread more evenly. Let's say, dito kay Surfactant, you have 4 ml and it's given in 4 aliquots. That means, first aliquot, 1 ml muna. Second aliquot is another ml. Third, 1 ml again, and fourth, 1 ml. So, the whole 4 ml is given, but paunti-unti, not one big installation. Why is this important in surfactant administration? So, sabi kanina, these small portions are less likely to plug the airway. Aside from that, it allows repositioning. After each aliquot, the infant may be repositioned so the drug spreads better to different lung areas. This also allows monitoring between doses. You can check if the baby develops desaturation, bradycardia, and poor chest rise. And it improves distribution instead of pooling in just one area. The surfactant has a better chance of reaching more alveoli. So, for Surfactant, that's 4 doses. Sa Infasurf, that's 2 doses, ang aliquots niya. And Curasurf, 2 doses din. Yan. So, another here, important to remember is the preparation of each surfactant. So, ang important for Surfactant, you do not shake it, but you need to warm it for 20 minutes. For Infasurf, gentle handling, and for Curasurf, warm to room temperature. So, important to never shake surfactant because it can destroy the structure. Remember, lipids tong mga to. And for the route natin is intratracheal through ETT. So for Surfanta, that's 5F catheter. For Infasurf, side port or catheter. And for Curasurf, katulad ni Surfanta, 5F catheter din. For delivery method, tingnan nyo na lang yung sa alikot natin. 4 alicots, then reposition for every alicot. For Infasurf, 2, and for Curasurf, 2 alicots. So, why reposition? Again, para evenly distributed ang surfactant sa lungs. Special notes dito, you need to ventilate between doses for Surfanta. And for Infasurf, you give time during with inspiration. For Curasurf, there should be no suction for 1 hour. You allow time sa Curasurf natin for surfactant to spread before suctioning. Available ba itong mga to, itong tatlong surfactants natin sa Philippines? Kasi parang hindi ko pa sila narinig dito sa Philippines. But yes, these are available, but limited lang sila for tertiary hospitals or sa mga NICU. Ang commonly used dito sa Philippines is the Curasurf or the Surfactant Alpha. Yung pork or yung pig ang kanyang source. Available in some centers yung ating Surfanta and less common yung ating Infasurf. You usually find them sa mga DOH tertiary hospitals, PGH, mga regional medical centers, CVMC, private hospitals with NICU, yung mga St. Luke's, Makati Med, and yun nga, nasa NICU lang sila. In reality, itong ating surfactants are expensive. Expensive sila and usually hospital supplied lang, not available sa ating mga regular pharmacies. Itong mga flashcards natin, same as yung ating comparison table na kanina, no? So, drill questions na lang for every flashcard. You can pause, answer, or just rewatch itong part na to. So, dito sa ating Surfanta or Beractant, what type of surfactant is Surfanta? So, answer there is, it's a modified natural surfactant, bovine. Ano naman yung standard initial dose for Surfanta? That's 4 ml per kilogram. Paano ina-administer ang Surfanta? So, intratracheally via endotracheal tube using a 5 French catheter. Kamukha niya yung sa last natin, yung sa pork. What is a key administration precaution for Surfanta? So, key dito, do not shake and warm to room temperature for about 20 minutes. And lastly, how is Surfanta delivered in terms of dosing technique? So, 4-4 ito, sabi natin kanina, given in 4 divided aliquots with repositioning after each dose. Drills naman tayo when it comes to your Infasurf or Calfactant. So, what type and source of surfactant is Infasurf? So, the same. It's modified natural surfactant derived from bovine or calf lung lavage. Question, for prophylaxis, which infants are indicated to receive Infasurf? So, ibang table to, no? Yung unang table natin. This is for premature infants less than 29 weeks gestational age at high risk for RDS. Another question, what is the standard initial dose naman for Infasurf? This is 3 ml per kilogram delivered over 2 doses. Next question, how often can Infasurf doses be repeated? And what is the number of doses na maximum for this? So, this is given every 12 hours, the same as the last one, yung pork natin, and up to a maximum of 3 doses. And last question, what are the key administration methods for InfaSurf? So, ETT din to, but using side port adapter or catheter. Let's look at itong pinaka-common sa Philippines, Curosurf. What type and source of surfactant is Surfactant alpha or Curosurf? So, it's a natural surfactant derived from pig lung. And what is the primary clinical use of Curosurf? So, it's not for prophylaxis. Yun ang very obvious sa table na natingnan natin kanina. It's for rescue treatment of RDS in premature infants to reduce mortality and pneumothorax. Ano naman ang initial dose for Curosurf? That's 2.5 milliliters per kilogram. So, mukha siyang konti, pero siya yung mas mataas ang concentration at 200 milligrams per kilogram. Paano naman ang dosing ng Curosurf continued after the initial dose na 2.5? So, this is kalahati, 1.25 milliliters per kilogram every 12 hours up to 2 additional doses. And lastly, ano ang key administration consideration for Curosurf? You need to warm it to room temperature, no need to reconstitute, and you administer also via ETT using 5 French catheter in 2 aliquots. Ang last na gusto kong itanong dito, what makes Curosurf clinically strong compared to others? Mas mataas ang concentration nito. And clinically, why is it stronger compared to the first two? This is because of the higher phospholipid concentration, may better spreading and faster lung expansion. Kahit na life-saving ang surfactant therapy, hindi siya risk-free. Very important ito because most complications are actually due to, number 1, the way we give the drug. Napahapyawan natin to kaya meron tayong mga aliquots. And number 2, the rapid physiologic changes after it works. It works pero sobrang bilis. So we need to anticipate and manage these immediately. Again, the way we give the drug and yung rapid physiologic changes. Number 1 natin, ito, airway occlusion, desaturation, and bradycardia. Unang complication and very common during administration. Remember, we are instilling large volumes into very small neonatal airways. So what happens? Merong temporary blockade, mababa yung oxygen level natin, mababa yung heart rate. So, biglang babagsak yung SAT natin, then babagal ang heart rate due to dosing. That's why, yung management natin dito kanina, we give in small aliquots and we increase ventilatory support temporarily. We also reposition the patient. So, hindi ibig sabihin nag-worsen ang baby, sometimes it's just because of the drug is entering. So, bakit parang mas nag-worsen si baby? Pag binigay mo yung surfactant. So, pumapasok kasi yung drug natin. Next natin is hyperoxia or high arterial oxygen. This is paradoxical kasi gumagana yung surfactant. Mataas yung oxygen, mataas yung lung compliance, yung alveoli natin open. Di ba yun naman yung gusto natin? Oxygenation improves rapidly. Masyado namang mabilis. So, if you don't adjust settings, yung ating arterial oxygen pressure becomes too high. Why is this dangerous? Kapag masyadong mataas yung oxygen, there's a risk for retinopathy of prematurity or ROP. Ano ba yun? Disease of the eyes, yung retina natin in premature babies because of abnormal blood vessel growth. And it happens kapag may high oxygen. Kasi yung oxygen disrupts normal vessel development. So, magiging fragile yung vessels. It can cause vision problems sa baby. So, how do we manage this? We immediately titrate itong VO2 or fraction of inspired oxygen and continuously monitor yung ating SpO2 or yung ating SAT, oxygen saturation. Third natin is, again, paradoxical, no? Overventilation and hypocapnia. So, as compliance improve natin, there's too much ventilation and yung carbon dioxide mo drops. So, ang consequence kasi nito, it can cause cerebral vasoconstriction. So, risk naman of brain injury and possible pneumothorax. Ano yung neurothorax natin? Alam nyo yan. The air leaks into pleural space outside the lungs. So, what happens dito? Yung lung magko-collapse. May hangin sa labas ng lungs, hindi na siya makapag-expand. So, the management here is reduce PIP rate or the tidal volume. After surfactant, the lungs change fast, so the ventilator must follow. Another complication is apnea. Apnea is because of airway manipulation or reflex responses. It can occur during or after administration. So we should monitor closely and be ready for ventilatory support. And finally, pulmonary hemorrhage. This is the most serious pulmonary complication. And this is the most consistent na nare-report. High-risk patients are those na very premature, low birth weight, and with PDA. Ano yung PDA natin? Patent ductus arteriosus. So, yung blood vessel, yung ductus arteriosus, fails to close after birth. So, after birth, dapat nagko-close itong ductus arteriosus natin. So, kapag nagbigay tayo ng surfactant, what happens is, pwedeng yung blood flow pupunta the wrong way. Extra blood goes to the lungs. So, yung effect nito, there will be fluid overload, respiratory distress. So, may shortcut na dapat nagsara pero naiwan siyang nakabukas kaya napupuno yung lungs ng dugo. It happens because of sudden high pulmonary blood flow or fragile pulmonary vessels. So, hindi pa fully proven ang exact cause, pero clinically associated to. That's why we always monitor for signs of bleeding after surfactant. So, again, dito, when you think about surfactant hazards and complication, it will only fall into two categories. Procedure-related, how you give the surfactant, and effect-related. Yun nga, paradoxical kasi yun gusto nating effect pero napasobra. So, yung procedure-related natin dito, the first three, airway occlusion, desaturation, and bradycardia. And effect-related natin, the drug works too well na nagkakaroon tayo ng problem. Ito, hyperoxia, hypocapnia, overventilation, and pulmonary hemorrhage. So, anong future ng ating surfactant therapy? Kasi hindi lang siya limited sa neonatal RDS. Marami pa siyang potential uses as surfactant and ongoing pa rin ang research for this one. So, expanded clinical application. So, originally, surfactant therapy is used for RDS in premature babies. Pero ngayon, tinitingnan na siya for other diseases. Surfactant is being studied for ARDS, natin, acute respiratory distress syndrome, MAS, or meconium aspiration syndrome, sa pneumonia, and sa acute lung injury. Sa RDS, ang problem is kulang ang surfactant. Pero sa ARDS, hindi kulang, but nasira or dysfunctional dahil sa inflammation. So, response to surfactant in adults is not as predictable as in newborns. Hindi lang neonates, pati adults pinag-aaralan na. So, pinag-aaralan din siya for lung plant patients, pulmonary fibrosis, sarcoidosis, and hypersensitivity pneumonitis, asthma, at saka mga drug-induced disease. This shows us that surfactant is not just for collapse, but also involved in inflammation and lung defense. Ayan, for these two. One of the most exciting developments is aerosolized delivery system or aerosolized surfactant. Remember, it is delivered through ETT. So, instead of putting surfactant through ETT, pwede na siyang i-nebulize using a vibrating mesh nebulizer. So, the advantage of this is non-invasive, no need for intubation, more patient-friendly. But, the problem is, magiging uneven ang distribution natin and goes to already open lungs na hindi naman kailangan na doon and not always reaching the damaged areas. Ito yung future goal naman natin, genetically engineered surfactants. Yung recombinant DNA, yung meron siya nung lipids, meron din siya nung proteins. Kasi wala pa tayo nun. And that is the goal, na maging man-made siya, laboratory-made, so that no infection risk, pero more effective compared dun sa synthetic natin ngayon kasi meron na rin siyang proteins. At the moment, still under development yang ating genetically engineered surfactant. So, wala ka pang makikitang available products. And the future direction is also about improved delivery and personalization. So, better dosing strategies, better delivery options or methods, and targeted therapy, especially in adults, because lungs are larger and disease is uneven. And syempre, as this last slide natin for every module, the respiratory care assessment of surfactant therapy. This is again and again the very important part for you as respiratory therapists. How do you assess surfactant therapy? Kasi hindi lang tayo basta nagbibigay ng surfactant. We need to monitor before, during, and after to ensure safety and effectiveness. So before treatment, ask yourself, yung infant ba is showing signs of RDS? Are there risk factors like prematurity, low birth weight? And remember, surfactant is not routine for all. It is indication-based therapy. During treatment or short-term monitoring, ito yung critical phase natin. Very critical. Nakita nyo naman yung hazards and complication kanina. You monitor first for cardiac rhythm and pulse. Ito muna. And then you next watch for airway occlusion, signs of desaturation, bradycardia. So if this happens, remove from ventilator, you provide manual ventilation, and you need saline lavage or suctioning. You also monitor for color and activity level of the infant. Kung cyanotic na ang itsura niya, that's not a good sign. Titingnan niyo yung chest rise niya, is ventilation adequate. Oxygenation monitoring is very important, yung oximeter natin, because after surfactant, oxygenation improves fast and there's a risk of hyperoxia which can lead to, sinabi kanina, yung ating retinopathy, ROP. We also monitor for carbon dioxide levels. So, sabi na to kanina. Because compliance improves and the risk of overventilation and hypocapnia increases. For long-term naman, after stabilization, we assess effectiveness. We look at lung mechanics, yung kanyang exhaled tidal volume, yung kanyang PEEP, and lung compliance. If surfactant is working, compliance improved, there's less pressure needed to ventilate. Also assess, do we need repeat dosing? Kailangan pa ba? Remember, some infants need multiple doses depending on response. And finally, sa general safety natin on contraindication, always reassess the patient's condition. If you see deterioration in pulse, cardiac rhythm, mga blood gases niya, you must consider, do we need to continue? Do you need to adjust? Or do you need to stop? So, yan ang kailangang pagdesisyonan. Because surface therapy works fast, but that also means complications can happen fast. And as respiratory therapists, you are not just giving therapy, you are actively managing and adjusting care in real time. That wraps our discussion for Module 10 on surfactant agents. And before we end, quick reminders lang. Please watch your classmates' reports. Hindi lang ito requirement. This is also part of your learning. Kasi baka mas maintindihan nyo sa report ng classmates ninyo. And don't forget to practice the way ground quiz. This is for mastery, hindi lang for grades because that is not graded anyway. Remember, surfactant is not just theory. This is something you will actually manage in real patients, especially in neonatal care. Nakita ko yan, no? Respiratory therapies working mismo sa PICU o Pediatric ICU natin. That's it. Next week, we will move forward to modules 11, 12, and 13. So, medyo mabilis na tayo from here. For our reporters, for those modules, you may send your recording beforehand, just like what the previous groups did, para ma-review natin early and mas smooth ang discussion. Alright? Keep studying, keep practicing, and see you sa next session natin. Bye, everyone!